Good afternoon, friends. Let us start a new topic today, that is Parkinson's disease or Parkinsonism, or it is also called as a PD. It is a degenerative disease, that is, there is a degeneration of some of the neurons, particularly which are responsible for dopaminergic pathway, and it causes the motor skill impairment. It affects the motor skills, speech, and other functions. This disease belongs to a group of conditions that is called as movement disorders. It is characterized by muscle rigidity, tremor, slowing of physical movements, bradykinesia, and loss of physical movements, that is akinesia, and that is in extreme cases akinesia is there. The primary symptoms are because of the result of decreased stimulation of the motor cortex by the basal ganglia. Normally it is caused by insufficient formation and action of dopamine, as I already told you that it is because of the dopaminergic neurons problem or degeneration, and it is produced in the dopaminergic neurons of the brain. Particularly one specific area is there to what we call it as a substantia nigra. We shall be seeing the figure which shows how the areas are controlling in few slides. After few slides we shall be seeing. There are secondary symptoms like high level cognitive dysfunction. Cognitive means learning disability, we can say. Cognitive dysfunction means disability in learning. Then there can be some subtle language problems. It is chronic as well as progressive disease. So it is originally described by James Parkinson in 1817, and he called it as a shaking palsy because the person who have the Parkinsonism or Parkinson's disease will shake, or there will be so many tremors, and many of them cannot hold some of the things in hand properly, cannot even have the pen nicely, or they even find difficulty in writing something. So it is like that. It is a chronic, slowly progressing neurodisordered disease of the basal ganglia. Basal ganglia is one of the area in the central nervous system. The basic pathology is a lack of dopamine producing cell in the basal ganglia. Let us classify it on the basis of what kind of reasons it may be having on the etiological activities. So most of the people are having Parkinsonism that is known as idiopathic, where no known cause is there. It is not known that what can be the reason behind it. Around 7 to 9% of the people, they have drug induced Parkinsonism. Anybody can tell me the drug which are inducing Parkinsonism? Anybody can tell me? Fourth year? Very good, typical antipsychotics. Good, Gayatri. And what we call it? What that adverse effect we call it? Yes. What is EPS? What is EPS? Extrapyramidal symptom. Very good. Very good, excellent. And what was the reason behind it? Why these drugs they cause yes, decreased dopamine, is it correct? They are antagonist of dopamine receptor. Which dopamine receptor? Fine. So we have seen that the drugs which are acting as a antagonist of dopamine D2 receptors, they are having the adverse effect like extrapyramidal syndrome, and this extrapyramidal syndrome is or symptom, these are nothing but the symptoms which are mimic on, they are almost similar to that of Parkinsonism. So all these drugs which are causing, they will call it as a drug induced Parkinsonism. Then in some patient it is Parkinsonism plus syndrome, that is along with Parkinsonism some of the central nervous system affecting problems are there, and we shall see one by one what are these. And like cognitive problems, then depression like states, and schizophrenia like conditions. We shall see all these conditions. Then in few people it can be vascular Parkinsonism syndrome, then toxin induced are there, which are very rare, small, and recurrent head trauma are there. They can, because of trauma, that area in the brain has damage, in CNS which is damaged. We have seen what area? Substantia nigra in the basal ganglia area, and this will be affecting. So these are various etiological classifications. So idiopathic, so it is at the place of origin is the basal ganglia. There is a loss of dopamine producing cells in the substantia nigra, that is abbreviation is used as a SN, and the locus ceruleus. The degeneration of this nigrostriatal pathway. Again, very interesting thing, I like those who are reading or will able to read it, particularly in various books about pathology and pathways. So in CNS these pathways will be very prominently mentioned at many places. Nigrostriatal means it starts in substantia nigra and it goes to striatum, okay, that is corpus striatum. So these are the way how we should understand it. We shall see this later also when we shall see the figure about it, how these are mentioned. So nigrostriatal, that means it starts from substantia nigra, that means the controlling center is substantia nigra, and the receiving area or the area which is getting controlled is the striatum. So this is the nigrostriatal pathway. So nigro comes first. If it is striatonigral, that means striatum comes first. Striatum is a controlling center, and then it is controlling the substantia nigra. So that is substantia nigra to corpus striatum. Then there is a manifestations that is decrease in the dopamine content by approximately 50%. This is the reason behind it, and because of that it causes loss of inhibitory input to the cholinergic system. Therefore there is excess or excitatory output of from the cholinergic system, and there is imbalance in the cholinergic inputs in the striatum. So cholinergic output which is excitatory that increases than the inhibitory output. We have seen various drug induced Parkinsonism, that is just now you have told, that is these are various antipsychotic drugs or neuroleptic agents. Example of these are haloperidol, chlorpromazine, thioridazine, risperidone, olanzapine. Out of that, risperidone and olanzapine, they are atypical one. They can also cause it, but yes, those which are typical antipsychotics, they are having more chances or more, we can say, probability of having these extrapyramidal syndromes. Some of the antiemetics which are again acting on dopaminergic, the example of these are metoclopramide and perchlorperazine. Then dopamine depleters are there, like methyl dopa reserpine, which reduces the dopamine, and but they are used in the treatment of hypertension. They are as a antihypertensive agents. Combination of drug like amitriptyline and perfenazine, these both are responsible for that. Amitriptyline is uptake inhibitor which can inhibit the uptake, and thus it can affect the D2 receptor mediated mechanisms. Then next is Parkinsonism plus syndrome, that is apart from the visible this signs and symptom, that is we call it as a motor or shaking palsy like symptom. There are additional effects it is there, that is there are also disorders of multiple system degeneration, and it is a group of neurodegenerative disease. They are featuring classical features of Parkinsonism like tremor, rigidity, akinesia, bradykinesia, postural instability. These are all motor function. Okay, this is there. So up to this is a Parkinsonism, but the additional features like they are having idiopathic Parkinsonism disease. So some may have Alzheimer's disease, which can be there, and atypical Parkinsonism or Parkinsonism plus syndromes are often difficult to differentiate from Parkinson's disease, and therefore they are more complicated and more troublesome to treat. So what are the things into it? They include multiple system atrophy. So at many systems are there, they will be atrophied. Progressive supranuclear palsy and corticobasal degeneration. So these are various things. Because of that, it will cause several impacts. Example of this is dementia. What is dementia? Anybody? Very good. Memory loss. So dementia will be there with Lewy bodies. This is very classic feature of Alzheimer's. That is dementia plus Lewy's body. This is the Alzheimer's sign. So it may or may not be the part of this Parkinsonism spectrum, but it is increasingly recognized as the second most common type of neurodegenerative dementia after Alzheimer's disease. These disorders are currently lumped into two groups, having synocleinopathies. That is, we shall see about this also. There is one protein, some structure that is synonuclein, and it is involved in that, and another is tauopathies. So these two things are mentioned again when we shall see Alzheimer's, that at that time we shall see how this tau protein is there, which is there, which is responsible in Alzheimer, or which has been found to be role in Alzheimer's disease. So these are the tau. So people feel that either this synuclein pathway or tau pathway are there. Additional syndrome includes Pick's disease and olivopontocerebral atrophy, that is again having ataxia and dysarthria. Ataxia again difficulty in movements or muscle coordination we can say, and dysarthria, that is the joints are there, dys and arthrias are joints, and because of that the joints are not properly aligned, or they are not working in a proper way. So these are there, they are inherited disorders, or they are acting as, or they are present as a variant of multiple system atrophy. It is also characterized by autonomic failure, and it was called as a Shire-Drager syndrome, but this comes along with that. Then we have seen earlier in one of the classification that there are some of the toxin which can cause Parkinsonism. Out of that, very prominent is known as a MPTP. Then this is one of the industrial chemicals: cyanide, iron, manganese, carbon disulfide or carbon monoxide, pesticides like various organic sulfur, organic phosphates, organic solvents, lead, methanol. These are again some of the toxic agents which will cause the Parkinsonism like effect. Then one more class we have seen earlier while classification, although it is very small one, but this is one more class, that is vascular Parkinsonism, that causes abrupt onset. Usually it is unilateral, that is only one side of the body is having stepwise, or there is no progression. Either it gradually increases or there is no progression, it will remain as it is. Other sign, it will cause hemiparesis, that is the oozing out of the fluids. Aphasia, hyperreflexia, the reflex will be increasing. Aphasia means having difficulty in eating. Infarcts will be appearing in the neuroimaging, and they will be helpful in the confirming the reason of that diagnosis of it. It will be done on the neuroimaging basis. Then few causes are there, other etiological factors. They can be metabolic or infectious causes, like metabolic if it is metabolic, then they can be reversible. Example of this is hypo or hyperthyroidism, hypo or hyperparathyroidism, liver failure, central pontine myelinosis. Rapid correction of hyponatremia is required in that case whenever it is happening. Infectious, there are certain infections like post-encephalitis, then Creutzfeldt-Jakob disease. Anyone knows, anyone have heard about this Creutzfeldt-Jakob disease? Other name of it? Once upon a time, it has created a big havoc in some of the Western countries. Infectious masses comprising this substantia nigra or basal ganglia and HIV. Why HIV? Because HIV can cause so many type of infection which otherwise people do not have, because in normal people immune system is quite good, and this good immune system will not allow to have infection and reaching to the brain. So these are the things which are there. Creutzfeldt-Jakob, anybody could remember? Okay, it was known as a mad cow disease. Very popularly it was called as a mad cow disease, and it was because of the infections in the bovine, that is in cows or bulls, and because of that it was because of certain proteins which were produced after infection, that was called as a prions and all, and this disease was leading to problem. For that purpose, in that countries for some period there was a ban in eating this beef and all such kind of meats. So this is various infections which can lead to problem. So what is the etiology? Again, why it is there? We have seen various etiological factors, and we have seen that the majority of people are having it as idiopathic because it is unknown. And whenever we say that it is idiopathic, that means it is having some genetic feature, because all of a sudden in some people only it is happening. So it is probably combination of genetic and environmental factors. I think I told you about a very good book for this psychiatric diseases or neurological diseases. Anybody remembers the name? Yes. Anybody tried about it? Stephen Stahl. Rima, very good. Anybody tried, got it downloaded somewhere? Okay. I am not sure whether latest editions are there or not. And this mentions very nicely about various diseases, including schizophrenia, depression, etc. That there are combination of many things in that. Genetic factors are there, because why some people are having problem and why some are having very good thing. So it was found that, or the Stahl has proposed it. Stahl has given very nice figures, sort of cartoon-like figures or some diagrammatic representation, and he shows very clearly that most of the diseases which are of neurological or psychiatric origin, there are three important features are there, and many times they overlap on each other. One is genetic feature, another is environmental factors, and third one is the nutritional factors. Environment means what is the ambience, what is the surrounding near that person. If it is a stressful surrounding from the childhood, maybe suppose either poor family or there are disputes going on, etc., and it is continuously bombarding, it is a stressful one, it is not a happy life. So this is an environmental factor. Genetically they are more disposed to that. So genetics plus environmental plus nutrition, these are the factors which can affect there, and it will vary from the person to person. Although the cause of Parkinsonism remains unknown, scientists have identified factors that can contribute to Parkinsonism in some patients. One of the important factor is age, that is usually people over the age of 60 have 2 to 4% risk of developing Parkinsonism disease, means they have more chances comparatively. It is slightly more common than women, generally less common among African Americans and Asians. 1/5 to 1/10 as prevalent in the whites, so whites are having comparatively more chances of that. In Africa, less common among the blacks than white. Environmental factors like physical trauma, exposure to chemical infections and nutrition, these are various factors. Rural living, strong and consistent finding is that the risk of PD is increased by rural living, exposure to well water, agriculture work, farming, wood pulp mill, steel alloy industries, maybe because of the pesticides and the herbicides which are causing to contribute the Parkinsonism disease. Toxins, these are conclusion, they are strengthened by the several identified toxins that induce Parkinsonism in the animal models and in human. So this was, MPTP was very popular, even it is used as a model to induce Parkinsonism in animals. It is identified as a concomitant in the batch of street heroin in the Berkeley in the 1980s, and later it has been found that it can be present at many places. Other toxicants are carbon monoxide, carbon dioxide, manganese, paraquat. Paraquat is one of the organophosphorus compound, mercury, hexane, ruthenium, toluene, and some genetics are there, that is rapid onset dystonia Parkinsonism, that is because of DYT12. Then Parkin mutation is there in the genes, X-linked dystonia Parkinsonism, that is DY3, autosomal recessive juvenile Parkinsonism, that is ARJP, and alpha synuclein. I told you earlier, synuclein and tau, these are various proteins which are there. We shall be seeing more about synuclein again. So these are various genetic factors which are found to be there. I told how AIDS are there because lead to symptom of Parkinsonism disease, because commonly causing dopaminergic dysfunction, because it causes corticobasal degeneration. Then Creutzfeldt-Jakob disease, I told you what it is, mad cow disease it was called as, diffuse Lewy body diseases, and oxidative stress which is there because of the dopamine oxidative metabolism which plays a role in the development or progression of Parkinsonism. The dopamine oxidation via MAO results in a formation of hydrogen peroxide. This is really very interesting in this is this all catecholamines. Catecholamines, which drugs are catecholamines, or which biochemicals are catecholamines? Okay, adrenaline, noradrenaline, dopamine, these all are the catecholamines, and when they are metabolized through MAO, then they cause formation of hydrogen peroxide. Hydrogen peroxide is a strong oxidative reactant, and this oxidative reactant can cause oxidative stress, and because of this oxidative stress or the free radicals which are generated, it can cause or it can destroy the area which is nearby, and that's why some of the neurons are damaged. So actually it starts with the overproduction of dopamine and over metabolism of it with this MAO, and then the area that neurons get damaged. This is one of the hypotheses behind this. So hydrogen peroxide normally cleared by glutathione. Hydrogen peroxide reactions with ferrous ions, they causes hydroxyl free radical, and it causes damage to lipid, DNA, amino acids. So I told you that there is an increase in the, when we say that dopamine was less, actually when we will go in treatment also, we will see that we are increasing dopamine. So basically dopamine is reduced. We know that there is a loss of dopamine, but at the same time we understand that why it was there, because of the excess of dopamine. So excess of dopamine was there, it was metabolized, and because of the metabolism, the free radicals were caused through hydrogen peroxide, and they caused damage of dopaminergic neurons, and because of this dopaminergic neuron loss or degeneration, there is a problem, that is there is a decrease in the dopamine. So this is actually the cycle of the Parkinsonism. And here there is increase in the dopamine turnover is there, which may be because of many reasons, and there is a decrease in the protective mechanism is one reason. There are, we call them as antioxidant. Glutathione is one of the natural antioxidants. So it is also believed that this natural antioxidant is reduced and therefore it is there. In some people it can be increase in the iron concentration because of in that particular area, and therefore there is increase in the lipid peroxidation. The reason is not clear why there is a more iron in that particular area, so etiology is not clear. In some cases head trauma is there because of the head trauma is there, and continuously there are damages are there to that area. So these are various type of activities are there, and because of 11% chances are more we are having severe head injury, they are having Parkinsonism. So if we go for diagnosis of Parkinsonism, so it is a characteristic symptom that affect motor control, that is it is the person will show tremor at the wrist. You know tremors means the shaky movements, cannot hold the thing properly, there will be shivering like activities. Bradykinesia, brady means decrease, kinesia is movement. Hypertonia, increase in the tone, muscle tone. Restic tremor is an oscillating movement, that is 4 to 6 hertz, that occurs when the patient is trying to be still, and it disappears. Important is it will disappears on action. Once the suppose person will doing some actions, then it can disappear, but initially there will be tremor, and still the person is in thinking over it, then the tremor will still there. But once the movement starts, because then the flow of impulses they start properly, and because of that this tremor goes away and it will disappear. So we have two types of tremors. One is essential tremor that persists even after movement, and cerebral tremor, that is the intentional tremor which is happening. So these are two types of tremors can be there apart from resting tremor. Then bradykinesia, already told you, that is slowness of a movement, usually experienced as a weakness or stiffness of the limb. Hypertonia is a increase in the muscle tone. Other typical features are stooped posture. We shall see some of the figures. Stoop posture, that is some bent posture, slow shuffling, fastened gait, GAIT gait. Anybody know what is gait? Yes, very good. It is a walking manner. Then we'll decide whether it is normal or not. Okay, gait can be normal or abnormal. But gait, second year student understood gait, GAIT gait. In alcohol also one of the effect is abnormal gait. Okay, that whatsoever you see the people are walking in a zigzag fashion, so this is abnormal gait after drinking ethyl alcohol. So it is a slow shuffling, fastened gait, reduce arm swing. The arm swings normally while walking, but it will be reduced. Facial appearance, it will be mask like hypomimia. Low volume speech, the voice will be lower. Excessive drooling of saliva can come out while speaking or during this. There was one hypothesis about it, that when it's or how we can make the stages. So stage 1 and 2 can be when the pathology confined to the certain structure in the brainstem and it has not yet in the substantia nigra. Brack was one of the scientists and very recently he has made this hypothesis. Stage 3 and 4, there is a pathology into the midbrain and basal ganglia, and then you can see the signs of this all motor activity, and changes spread to cerebral cortex, so which is a widespread one and can affect other functions also, as we have seen, that is plus type of activities, that is Parkinsonism plus we have seen. So additional activities are there, that is our stage 5 and 6, where cognitive as well as other functional problems will be there. Brack stated that actually the first sign, although we say that it is a central nervous system degenerative disease and the first sign starts and then there are problems in the muscular activities, and these muscular activities are reflected in various things to what we call it as a this tremors and rigidity, this bradykinesia, etc. So all these the things are there, and but before that Brady told that Brady's hypothesis is that actually it starts in the enteric nervous system. Enteric means in the GIT, and it is supported by the evidence that the Parkinsonism, the non-motor symptoms like constipation may also appear, and they will appear before the motor symptoms. So he told very clearly that the constipation will be there, and that will appear, that will be the initial sign. And then Barak hypothesized that the alpha-synuclein can spread from the gut via the vagus nerve to the midbrain, and where it selectively kills the dopamine neuron. So initially it is in GIT. From that, this alpha-synuclein, as I told you, one of the protein, we have seen various pathways, tau and alpha-synuclein. So this alpha-synuclein which is formed there, it will be taken up by the vagus nerve. It will go reversely, that if you know vagus now, that the centers are present in the brain, that is at various places, and their ends are there, they are in various smooth muscles. So vagus nerve has got the, if you know about, it is a craniosacral one. So it has got the nucleus in the cranium, and the ends are there at various places from face, oral cavity and GIT. So this vagal nerve, from GIT this alpha-synuclein will be taken, and this alpha-synuclein will spread to the vagus nerve to the midbrain, and it will cause killing of the dopaminergic neuron. So this is one more hypothesis which is there. We have seen that what can be the non-motor symptoms of Parkinsonism disease. So it can be neuropsychiatric like dementia, depression, apathy, anxiety, loss of libido. Then autonomic, that is it will be constipation, urinary incontinence, that is will not able to control urine and can urinate at any places, erectile dysfunction, excessive sweating, postural hypotension, excessive salivation, we have seen just now drooling we called it recently. Then sleep disturbances, REM sleep disturbances, then dreams, daytime somnolence, that is daytime sleeping, dystonia, the changes in the tone, sensory symptoms will be there, pain, paresthesia means even though there is a no pain object is there in that area, still there is a sense of pain or abnormal feeling or like burning sensation, etc. So this type of things are called as a paresthesia. Signs and symptoms of Parkinsonism disease, we have started with that, that is there can be motor symptom, non-motor symptoms. Along with that it can be cognitive, neurobehavioral symptoms, sensory and sleep difficulties, they are also common. And motor symptom, definitely they are there. So basically what these are: motor symptoms, neuropsychiatric, sleep, perception or cognition we can say, autonomic, gastrointestinal, constipation we have seen, neuroophthalmological, in vision disturbances. So these are various problems. What are very common motor symptoms are tremor, rigidity, bradykinesia and postural instability. We shall see one by one. See, you can see the figure that this is the hand position, and you see two shadow like images. So that means the hand will move in these two direction and this type of tremors will be there. It is a pronation supination tremor, that is described as a pill rolling. So when the pills are rolled, that is those who have done formulation in pharmaceutics, so pills are rolled, just hands are moved for rolling pills, and this will give this movement that somebody is just like rolling pills, or that suppose hand on hand we keep, then they will not remain stable, and you will find that they are rubbed against each other. So we'll call it as a peel rolling like action. So it is having frequency of 3 to 5 hertz. Hertz means number of movements per seconds, suppressed by activity. So when there is activity, it will be suppressed. When hand will do some activity or lift some object, then it will stop. During sleep it will be stopped. During concentration on some activity, then there won't be any tremors. These are intensified by stress and fatigue, and usually begin unilaterally, that is only one side will start first and then it will be there. Then next is rigidity. It is joint stiffness and increase in the muscle tone. There is a increase in the resistance to passive movements of a joint. Oscillating, that is cogwheel type of activity, or smooth, that is lead pipe. These are the names given. Cogwheel means what happens is instead of a very clear movements, jerk like movements will be there, just like a machine or a robot like movements will be there. You might have seen how the robot is moving. It is not as the normal people walk. So because of the mechanical wheel like, gear like structures are there, so as the wheel passes, so wheel like activities are there, that is a cogwheel activity. This, so we call it as a oscillating activity, or smooth like a lead pipe activity. Rigidity usually tested by flexing and extending the patient's relaxed wrist. Wrist is flexion and what we can say supine, this extension and flexion type of actions or movements. In first year anatomy you might have seen it. So that is the this flexion and extension activities will be there. Particularly relaxed wrist activities are done, and if it is found difficult, then it can be diagnosed that yes, there is a rigidity. In combination with the resting tremor, this produces a rachetic cogwheel rigidity. As I told you, cogwheel means when the limb is passively moved, it may be associated with the joint pain, and it somewhere slows down, it gives a break or jerk like situation. So person will have a machine like movement instead of normal good movement. Bradykinesia and akinesia, it refers to slowness of movement, while the latter is absence of it. Means in akinesia there won't be any movement, or it will be too difficult to have the movement. Brady means it is a reduction. So most characteristic clinical feature of Parkinsonism, and it produces the difficulties not only with the execution of movement but also with the planning and initiation. Now very important thing is for all movement, consciously or subconsciously, the movements are planned, because whatsoever movement are done, they are through skeletal muscle, and unless and until the brain orders about it, this movement won't take place. So all these movements are there, its planning is done, the brain plans about it and then initiates it. I hope you have gone through many terms of that, like that, what is the basic muscle condition at that time. So continuously sensory inputs are going about which kind of muscles are located in what conditions, and accordingly brain orders, so that when you move the pain or when you move anything, then that particular order is there, because brain is continuously getting that signals. So this is how activities are there, and these all are, that is planning and execution, these all movements are affected. And rapid repetitive movements, they produce a dysrhythmic and decremental loss of amplitude. So the rhythm is lost, and the amplitude of that movement will also reduce. Then these people will have postural instability. It is the fourth cardinal or most important sign, but it emerges late in the disease after almost 8 years or more. There is an imbalance and loss of writing reflex. Writing reflex usually is studied in animals, that is when the animals are turn, they have, you might have seen rats are having their own simple position, or even human beings, we say that. So when they are tried to dislodge from that position, they try to correct to the position. So rat, if you try to put them on back, they will try to get correct himself on the paws. So this is called as a writing reflex. Or when somebody try to push the person, then the person immediately will act and the balance will be made so that the person do not fall down. So these are the reflexes which will try to keep the person or keep that particular animal in the usual position. So this will be imbalanced into that. Its emergence is an important milestone because it is poorly amenable to treatment. Means once it reaches, then it becomes very difficult. That person, that means going towards a bigger neurological damage, and that is becoming a common source of disability in the late disease. The person is having more problem into this. Then patient of stoop forwards posture, if it is there, then we can assume that yes, there are chances of postural instability. The presence of festinating gait pattern, that is stumbling forward, is a gait changes in that, and retropulsion can also occur, that is backside also there, because we have seen stooping forward is there. The person is almost it will feel that it will fall ahead. Okay. Decrease in arm swing during the ambulatory activity. While walking, the person will have the arm swing normally occurs. हाथ चलते दोनों आदमी के whenever person is walking, but they will be also reduced. So these are the signs: rigidity and trembling of the head, गर्दन हिलेगी, then forward tilt will be there from the trunk. You can see the posture, you can see the bend, if you see the angle from the angle at the trunk. Okay. Then rigidity and trembling of the extremities. So hand and limbs can have the tremors. Then reduced arm swing is there. So while walking, it will almost stay walk without that limb movement. Shuffling gait with short steps will be short, and the gait will be there. So head will be held forward, drooping eyelids, tremor of hands, then slow shuffling gait. These are the manifestations, and see how gradually it is there, how these are the posture disturbances. You can see almost bending forward. So this bending forward, these are the various postures which are there in the Parkinsonism disease. Then other sign symptoms are the neuropsychiatric one. We have already seen this, that it causes neuropsychiatric diseases like cognition, mood and behavior problems, and it can be as disabling as the motor symptoms. We have seen that what are the psychiatric problem can be, that is depression, then maniac and other activities. Cognition means the learning will be impaired. The mood and behavior problem, mood swings will be there, manias and depressions like activities will be there. Behavior problems will be there, and it will be more disabling, or it will be as disabling as the motor symptoms. Then executive dysfunction will translate into impaired set shifting, poor problem solving and fluctuations in the attention, among the other difficulties. So they will not able to pay attention, they will not able to go for problem solving skills, and there will be set shifting, that is from one activity to other activity. When they have to shift, they will find it difficulty. There will be decrease in the cognitive speed, that is called as a bradyphrenia. That means the learning will be impaired. They will not understand the things that easily, and they cannot respond that easily. Just like, you know, when I am asking question, and some can answer quickly, some can reply. So their cognitive functions are good. But in some people, they do not understand that there is some question is asked, or it can have some solution. So this is what we can say is slow cognitive speed. So there is a decrease in the cognitive speed in these people. There can be memory problem, particularly in recalling learned information, which is important improvement with the cues. That is when we give some activities. Recognition is less impaired than the free recall. That is pointing towards the retrieving more than to an encoding problem. Language patients are found to have problem in the verbal fluency test. Visuospatial skills are difficult. They are seen when the person with Parkinsonian disease perform the test of facial recognition and perception of the line orientation. Then they will be difficult for that. Then we have seen about depression, apathy, anxiety. This can be there. Sleep can be problem. Excessive daytime somnolence. Daytime sleeping will be there. During normal sleeping period, there will be insomnia, mostly by sleep fragmentation. Sleep will not be proper. Disturbances will be there in the REM sleeps. Perceptions like impaired proprioception. I told just now what is proprioception. That is awareness of the bodily position in the three-dimensional space. Because if I have to write, just now I was giving you this example, that is continuous sensory input is going to the brain, that where my tissue is, where this muscle is, and how much movement I have to do. Suppose I have to make some writing, then that too on the in between two lines of a page, then my brain knows where my hand is, how my muscles are placed, and all these muscles, how I have to write. So this is what proprioception is, because of knowing that the movements of the muscle, it doesn't go beyond the line, it remains in the line, it goes in particular segment, it doesn't go in one letter or another letter. This can happen because of the proprioception. Why? Because the brain is fully aware about what place the tissue is there, particularly muscle is there, and how much movement it will require to do that necessary action. So this is how proprioception plays important, and if it is impaired, then as we have seen, that is execution and planning of the muscular activity will be affected, because for planning and execution proprioception is very important. Then reduction or loss in the sense of smell, that is hyposmia or anosmia can be there. Then there can be pain, that is neuropathic muscle, joint and tendon pains will be there, that will be attributable to tension. Dystonia, rigidity, joint stiffness and injuries associated with the attempts at accommodations. Orthostatic hypotension can be there, then leading to dizziness and fainting. Orthostatic means we call it as a postural also, when there is a change in the posture, that blood pressure which is required to, particularly from lying supine to getting up and standing. So from lying to standing, when the person changes the posture, then if that causes hypotension, because of that, or that blood pressure is not modulated accordingly, then it can cause dizziness or fainting. Oily skin and seborrheic dermatitis it can cause. It can cause urinary incontinence, it can cause altered sexual function, it can cause excessive sweating in the people. In GIT, decreased motility, constipation, and neuroophthalmic complication are stare look. Stare look means without any understanding, continuous looking like that, and the stare will clearly show that person is not understanding, it's just staring without any emotions behind it. Then irritation of eyes, decretion of convergence of eye, that is blepharospasm. These are various activities it will cause. How will stage it? Just a minute. हाँ अमरपाली, हाँ गुड माझा क्लास सुरू आहे माझा. हाँ क्लास सुरू आहे माझा, मग थोड्या वेळानंतर ते सगळे फ्री झाले. क्लास सुरू आहे, क्लास. हाँ पण माझा क्लास सुरू आहे, तुम्ही सुरू करा, आलो मी. हाँ थोडा वेळ सुरू आहे, आलो मी, संपला की. बरं जस्ट हॅलो. हां हां हां, एक 15-20 मिनटं लागतील. So if we have to make the staging, because it is very important in therapeutics, that is what are the severity. So at stage 0 no clinical signs are evident, but if you remember just now we have seen the hypothesis of Brack, and it shows that initially it can be constipation and which will then result into these activities. So initially no clinical signs evident, maybe constipation like it will be there. Then it is unilateral involvement, that is what are the major signs are, we have seen motor signs like tremors, rigidity, bradykinesia, etc. Stage 2 is bilateral, no postural abnormalities. Stage 3 bilateral and mid postural imbalance. We have seen figures of postural imbalances leads an independent life. It is possible still to the patient to have the life without any dependence. But stage 4, it is a bilateral postural instability, but it requires substantial help, okay, because may not able to walk its own, may not able to do most of the activity at the own. So this is stage 4, and it is severe, patient restricted to bed or wheelchair. This is the stage 5. So these are various stages, and accordingly we can have different treatments for that. Before that, again we shall go for some of the pathophysiological reasons why there is a Parkinsonism. We have seen the reason. The most important reason we have so far discussed and found that the reduced activity of pigmented dopamine secreting cells, these are reduced, where they are dopaminergic cells are almost everywhere in the brain, but in particularly some area like pars compacta region of the substantia nigra, we call it as a substantia nigra pars compacta, or in books you will find it as a SNPC. So it is called as a black substance. This neuron project into striatum, we shall see all this, and there leads to alteration in the activity of the neural circuits between basal ganglia, which causes regulation of movement. There is a GABA, and substance P of the direct pathway will be diminished, leading to less inhibition of the pars reticulata, that is substantia nigra, pars reticulata, and internal globus pallidus, and inhibition of the indirect pathway by the this GABA and enkephalins. So we shall see in a figure later. The direct pathway will have the movements that will inhibit the movements. So direct pathway will facilitate the movement, and the indirect will be inhibiting the movement. The loss of this cell lead to hypokinetic movement because indirect pathway will be affected, and the lack of dopamine result into increased inhibition of the ventral anterior nucleus of the thalamus, which sends excitatory projection to the motor cortex, and thus it leads to hypokinesia. There are 4 dopaminergic pathway in the brain. Again we shall be seeing all this. Nigrostriatal pathway, I told you about it. Nigrostriatal means what? From substantia nigra to corpus striatum, mediates movement, and the most importantly affected during Parkinsonism. Other pathways are the mesocortical, mesolimbic, and the tuberoinfundibular. These are important dopamine pathways. Out of that, this pathway will be affected most. The mechanism by which the brain cell in the Parkinsonism are lost, there are many reasons behind it. We have seen one of the very important hypothesis that it is because of the accumulation of protein that is known as alpha synuclein. If you remember again the hypothesis we have just now seen, it shows that alpha synuclein travels through vagal nerve, and therefore initially it shows the symptom in the GIT, that is constipation, and then it comes to vagal. From vagal it goes to CNS, it shows actions over there, and then it is selectively reaches to dopaminergic neuron and causes damage. It binds to ubiquitin in the damaged cell. Ubiquitin is the protein which plays a role in the own phagocytosis or damage. This alpha synuclein ubiquitin complex cannot be directed to the proteasome, and this protein accumulation forms proteinaceous cytoplasmic inclusion. They are called as Levy bodies. So this alpha synuclein and ubiquitin, they will be forming, they are called as Levy bodies. the latest research on the pathogenesis of the disease has shown that death of dopaminergic neuron by alpha-synuclein is due to the defect in the machinery of that transport the protein between two major cellular organelles like endoplasmic reticulum and the Golgi apparatus. So this excessive accumulation of iron which can be toxic to the nerve cell is also typically observed in the conjunction with this synuclein protein, and this all along with copper will bind to the chemical that is neuromelanin in the affected neurons, and they will be neuromelanin may be acting as a protective agent, but this iron and synuclein, they will cause the oxidative mechanism, and the dopamine and the byproduct of the dopamine production, they will cause increase in the alpha synuclein aggregation. What are the byproduct of dopamine degradation? We have seen them earlier. What are these? They were the hydrogen peroxide and the free radicals. So because of that, this will cause damage to the dopaminergic neuron. The recent view of Parkinsonism disease that shows the specialized calcium channels that allow substantia nigra neurons, but not other neurons, to fire in a pacemaker like pattern. If you remember epilepsy and the what we can say arrhythmia chapters wherever you have studied, so some of the cells, they all of a sudden starts emitting such kind of activities, and they act like a pacemaker, or they starts firing impulses. So because of that, the flooding of calcium into this neuron may aggravate damage to mitochondria, and it will cause cell death, because calcium is also known for as a mitochondrial death agent, and if the mitochondria is died, then the energy house of the cell will not be there and will result into cell death. So if we see the pathophysiology of Parkinsonism disease, which we shall do in next, that these are the areas, that is in corpus praetum, various areas are there. Example of these are very close to thalamus. They are part of basal ganglia, that is caudate nucleus, putamen and globus pallidus. They are having their activity, and through that they are sending their impulses through cortex, and from cortex through thalamus, and through thalamus it is going to the midbrain to the spinal cord. So this is how they are going. We shall see the basic structure in our next class. This is the figure which I have taken from Goodman and Gilman, which explains various neurotransmitters which are involved and the process involved. So I hope you are understanding this. If you have any difficulty, you can ask me. And once you understand what kind of disease is, you people have already, and how we have graded it. So on that basis, what treatment it can be, we can see it. Particularly for therapeutics, then it will be different. That is, what is the treatment for various kind of grades, what is the first line, second line treatment, and for second year we will go for the mechanism of action of various drugs which are there. If fourth year want to get it revised, then they can sit in second year class, and if the second year student wish to have the information about the therapeutical approach about it, they can have it. The separation now will start, because there will be pharmacology of various drugs which are there in, which are used in the treatment of, already fourth year student have studied it in second year, and they will just have a active study of various therapeutic regimens which are most suiting at different stages, and what are the guidelines they are telling about it. So we will go for guideline. This is what, because pathophysiology is common for both, therefore I have taken it. What is the pathophysiology? Tomorrow we will finish, actually tomorrow we will have one class, and then we will separate from this. We will have the class on this pathophysiology, and then we will go for separation from the next classes. So if you have any difficulty, you can ask, and you can communicate also those who want to sit, attend the classes. If the time permits, then we can plan it accordingly. Second year classes, the regular time is same, that is 2 to 3 only, and we have not changed it at all. So we can do it accordingly, and whenever the fourth year class is, I think 12:30 she is planning. So if it is 12:30, then second year student can sit into it. So accordingly you can inform me so that we can do it, so that all can attend it. So take care, and if you have any difficulties you can definitely ask.